an average glomerular hydrostatic pressure is about 55 millimeters of mercury. Okay? That's a force that's favoring outward movement of fluid inside you. It's opposed by these other two factors. A typical capsular hydrostatic pressure might be 15 millimeters of mercury. Oncotic pressure might be about 30. These are opposing forces. So to calculate the net filtration pressure, we take the hydrostatic pressure and subtract from it these other two factors. 15 plus 30 is 45. We do the subtraction. We get a net filtration pressure of 10 millimeters of mercury. That's the force that's responsible for filtration. Now, the higher this number is, the greater the filtration rate. Because the higher that net force is, the more fluid we're pushing across the filtration membrane. The lower that number is, the lower the filtration rate. Let's look at some examples here. Let's kind of discuss this. Let's suppose JJ is walking in an area where she has no business going. And somebody surprises her, walks up from behind, and JJ says, "You better move or I'm going to smack you." That's something she might say. Okay? And the person pulls out a shank and shanks it. Okay? And she's bleeding on the street, and some good Samaritan comes along and picks her up and brings her to the hospital. But in the hospital, when they first assess her, the blood pressure's only like 80 over 50. Okay, why? She's losing blood, she's losing volume, and that impacts blood pressure. And so one of the things they're going to do when you come into the hospital in this setting is they're going to rapidly start a couple of IVs, large bore IVs, where they can pump in some fluids. At the same time, they're going to put a forward catheter in to measure your urine output. So they're going to keep a close eye on input and output. It's called INOs. Okay? And they're going to find out that when she comes in hypotensive, she has very little output. She's not peeing. Okay? If you have a low urine output, that's called oliguria. If you have no urine output, by the way, that would be called anuria. So let's say she's either oliguric or anuric when she comes in. Well, what's the reason that she's not peeing? If her blood pressure is falling, then what's going to happen to her glomerular hydrostatic pressure? That's going to fall. So if her glomerular hydrostatic pressure falls to 45, let's say, then 45 minus 45 is 0. So she has no force within the glomerulus that's favoring filtration. So if she stops filtering, there's no filtrate from which to form urine. So she stops peeing. And you have to have blood pressure too. And there's a lesson in that story, above and beyond A and P. Yeah, that was the lesson I was going for.
I'm actually about to buy one.
No, I'm worried about it.
It's like a flashlight, so they don't know when the flashlight is wrong.
Oh my.
Because I definitely need one of those.
All right, so let's look at a different scenario. Let's draw our corpuscle. So let's say here's the renal pelvis. And again, it doesn't exactly look like this, but that's all right. Minor calyx. Here's your collecting duct, and here's your renal tubule here. Let's suppose somebody has a kidney stone that is obstructing the ureter. Whether it's obstructing at 90% or 100%, not too much of a difference here. This person here, with a kidney stone, at least on this side, that kidney is going to stop filtering. Why does that person stop filtering?
Pressure builds up.
Pressure builds up. Pressure builds up behind the obstruction and moves retrograde into the minor pelvis, into the minor calyx, into the collecting duct, retrograde to the renal tubule, and into the capsule. So that if capsular hydrostatic pressure climbs, such that now the sum of the capsular hydrostatic pressure and oncotic pressure are equal to hydrostatic pressure, then your net filtration pressure falls to 0. And you quit filtering. That kidney is no longer functioning. Now, earlier we said that in a normal individual, we don't see protein in the urine. So that anytime someone has protein in the urine, what do we call protein in the urine? What's the term for that? Proteinuria. So anytime someone exhibits proteinuria, there's something wrong. Okay? Why is it? So the two most common causes, by the way, of end-stage renal disease are long-standing hypertension and long-standing diabetes. So for diabetes, we call it a diabetic nephropathy. In these diabetics, long before they develop end-stage renal disease, they start to exhibit proteinuria. Why is it that these patients with diabetic nephropathies exhibit proteinuria?
Low blood pressure.
It's not low blood pressure. It's the fact that ordinarily what prevents proteinuria is the size of those filtration slits, the size of the openings within the filtration membrane. With diabetes, you develop damage to the filtration membrane. So it creates bigger holes that now allow larger molecules to pass through. And so you start to see the development of proteinuria early on, long before they develop end-stage renal disease. Now, you can imagine if filtration rate is dependent upon this net filtration pressure, that if net filtration pressure were to vary throughout the day, then your rate of filtration would change constantly. If your rate of filtration changes, if you start filtering more, you're going to start peeing more. Okay. You go through something, if you're exercising and your blood pressure goes up, you would have an increase in hydrostatic pressure, that would increase your net filtration pressure, and as soon as you finished exercising, you'd want to urinate, right? Because you'd be filtering more. The truth is that that doesn't occur. This has been looked at. We said that glomerular filtration rate, the amount of filtrate we form per minute, is the direct reflection of the net filtration pressure. Okay? It turns out that we have a fairly steady glomerular filtration rate. It doesn't vary throughout the day that much. Very little variation. And for most of us, if we have normal kidney function, that glomerular filtration rate is about 125 milliliters per minute. That means 125 milliliters of filtrate are formed from the blood every minute. Now, there are 1,440 minutes in a day. So if we filter 125 milliliters over the course of a minute, how much filtrate do we form over the course of a day? Okay, this is kind of like an algebra problem. Can anyone figure that out? We form 125 milliliters per minute of filtrate over the course of a minute. How much filtrate do we form over the course? You would need a calculator for this.
She just figured it out.
How much is it? Can somebody figure it out? How much?
How many minutes in there?
1,440, 1,440.
She, is it 180,000?
Yeah. 180,000. So we form 180,000 milliliters of filtrate per day for 24 hours. Okay. Another way of saying that is we form 180 liters of filtrate per day. Now, urine is derived from that filtrate that we form. And typically, most of us form at most 1.8 liters of urine per day. How can that be? If we're forming 180 liters of filtrate, why is it we're only producing 1.8 liters of urine? How can that possibly be? Yeah, what this tells you is that 99% of this filtrate gets reabsorbed, so that we only pee out about 1% under normal circumstances. Because if we were truly losing 180 liters, we would be dead within a matter of a few hours. In fact, we only have about 5 or 6 circulating liters of fluid within our bloodstream.
You said we would be dead if we...
Yeah, we'd be dead because we'd completely,
We're losing all our...
we'll lose all of our volume.
Okay.
We only have 5 or 6 liters of circulating blood volume, so you'd lose it quickly. Okay? Now, so we're steadily forming filtrate, which in turn, most of which gets reabsorbed. Okay? We said that the glomerular filtration rate is directly proportionate to net filtration pressure. So if we said net filtration pressure falls to 0, we stop filtering. Okay? Now, and that can occur if your blood pressure falls to very low levels. Okay? But the fact is that over the normal range of blood pressure, our GFR, our glomerular filtration rate, remains steady. Why? Because the kidneys have evolved mechanisms to maintain a steady GFR despite normal fluctuations in blood pressure, which otherwise would increase or decrease your hydrostatic pressure and affect your net filtration pressure. Turns out that net filtration pressure over the normal range of blood pressure remains stable. So now what we're going to talk about is those mechanisms that the kidneys have evolved. Okay? If those mechanisms are self-contained within the kidney, we call those intrinsic mechanisms. Okay? Intrinsic control mechanisms. Or another term for this is renal autoregulation. If those mechanisms extend outside the kidney, these are extrinsic control mechanisms. These are neural, mediated by the nervous system, and hormonal. Okay. So let's talk about renal autoregulation, these intrinsic mechanisms that tend to maintain a steady GFR. The first of these is the myogenic mechanism. This is fairly straightforward. Let's look at the afferent arteriole that's feeding blood into the glomerulus. If blood pressure is high, if blood pressure goes up, okay, then that high blood pressure is going to be transmitted to the afferent arteriole, and that high pressure is going to stretch the walls of that afferent arteriole. The myogenic mechanism is simply a reflex mechanism in which, as the walls of the afferent arteriole are stretched, it triggers vasoconstriction. The smooth muscle contracts and the vessel narrows. When that afferent arteriole undergoes vasoconstriction, what it's doing is increasing resistance at this point to blood flow into the glomerulus. So that that high pressure head within the systemic circulation doesn't reach the glomerulus. Yeah, pressure may climb from 55, a mean pressure of 55, up to, let's say, 75. Okay? But that 75 millimeters of mercury isn't transmitted to the glomerulus because of the increased resistance, the opposition of blood flow. So less blood is going to flow in, so that within the glomerulus, you maintain a hydrostatic pressure of 55. So there'll be a pressure gradient that occurs across this area of narrowing. And that pressure gradient serves to maintain a steady hydrostatic pressure. So if the hydrostatic pressure doesn't change, net filtration pressure doesn't change despite the increase in blood pressure. Now, the afferent arteriole has a fairly steady tone. In other words, a smooth muscle that lines the arteriole has a fairly steady degree of contraction. If the blood pressure begins to fall, which would lower hydrostatic pressure within the glomerulus, what does the afferent arteriole do? When it senses decreased stretch, it relaxes. And so if blood pressure falls and the afferent arteriole undergoes vasodilation, it allows more blood pressure into the glomerulus that maintains the blood pressure in the glomerulus so that there's not a drop-off. If the glomerular hydrostatic pressure remains the same, 55, that means net filtration pressure doesn't change. So this is one mechanism, an intrinsic control mechanism that serves to maintain a stable net filtration pressure.